That really is a good thing about Thanksgiving, I think. Okay, all right. Has anybody got anything for me before I get going? Nope. Okay. All right. So I understand that symptomatic. First off, let me say this about that that video in thoracic discogenic pain. If I didn't make it clear, I'll do it now. Nobody seems to have done any real work on the thoracic spine, anatomy, mechanics, pathology, or clinical studies. There really is a dearth from it. And what they seem to do is assume that it's much like the lumbar spine and the cervical spine, which is interesting because the lumbar spine and the cervical spine are nothing like each other. So you have to wonder just where their brains are on this. It needs more work done, and maybe it'll get done, maybe it won't. But everything I said in that video is qualified by that. It really wouldn't surprise me if pretty much everything I said there in a few years' time turns out to be, if not downright wrong, sort of certainly at least some of it's not going to be right, that's for sure. The problem is I can't even give you information from my experience. I don't think that I've ever knowingly treated a thoracic disc herniation. So all I am is a compiler of the information I can find, and there's not a lot of it. So some of the questions you asked me are asking me stuff that I simply don't know, but we'll go over it anyway. Does anybody want to comment on that? Nope. Okay. All right. So having said all that,
thoracic, from my point of view, thoracic disc herniations, they present differently. It's like all other ones. Like some are mildly symptomatic, some are just terrible. The real large ones can be terribly painful when you see them. You see those patients, so they're acute. So you think about it much like in the lumbar spine, where you get this array of what you may see based on the disc herniation and just kind of how that individual case presents. There's not a hard and fast rule to them.
No, but they're all like that. So basically what I've done is I've done the same thing as everybody else is doing. I'm assuming that clinically a proper symptomatic disc herniation is going to be like a lumbar disc herniation. That is, it's going to be a severe problem, whether there's neuropathic findings or not. Anything milder than that, you have to question whether or not the MRI, which may show a disc herniation, is actually showing a relevant disc herniation. As I said on that, up to what, 40% of disc herniations are asymptomatic. They're just found in the general population. So you've always got that problem. It's same in the lumbar spine, same in the cervical spine. You find a problem in the spine, you do an MRI on it, and if the MRI is positive for a disc, that's what the patient has. What you should be doing is diagnosing a disc and then using the MRI as a confirmation, not as a diagnostic tool. The problem is in the lumbar spine, unless this is outrageously obvious, it's almost impossible to do that. But I don't think that's any really different. The only thing you can say about thoracic discs that everybody agrees on is that they're bloody rare, extremely rare. But even there, there's no good evidence of that, simply because if you look at the frequency of disc herniations, estimated disc herniations based on studies, it's anywhere between 1 in 1,000 and 1 in 1 million. That's 1,000-fold difference. So it means that they have no idea what they're really talking about. That's really what it comes down to. When you've got that sort of a gap between what it might be and what it is, you've got no idea. None at all. Neither do they. So you're really in the dark with this. I think you really have to concentrate on the neurological signs and symptoms. So if you're finding a radiculopathy there, the chances are it is probably a disc herniation. And that's much like the lumbar spine again. If you find a myelopathy, then it may or may not be due to a disc herniation. It doesn't really matter to you though. If they've got a myelopathy, that needs to be diagnosed fairly quickly and definitively by somebody else, not by you. Also, you've got the issue with 40% of disc herniations, according to these numbers anyway, 40% are painless. So they're showing up because of neurological signs, maybe paresthesia, but you have to go looking for signs. And my guess is this is going to be myelopathic rather than radiculopathic. Is that okay for an introduction? Because there's just nothing else I can tell you about it, really. Which is really quite annoying when I'm going to answer the questions now. So, all right, this is the first one. I understand that symptomatic disc herniation is not commonly seen, but what does your clinical presentation EIS look like for this group of people? I don't know. I really don't know. I'm assuming it's going to look like a lumbar disc herniation, but that's as far as I can go. I don't know if you have the same sort of thing with bulging that you get with lumbar disc herniation, the lumbar spine. I have no idea. I don't even know if the nucleus survives in these people past youth. I really have no idea about it. Degeneration isn't well documented in this. There's nothing about this that is good. Since there are a few ways to test for reflex and myotomes in the thoracic spine, you mostly make your diagnosed patient subjective report symptoms. Why the thoracic herniations present more like Brown-Sequard syndrome? I don't know about that. I have no idea why that would be bilateral when it's a unilateral herniation. I really don't know. It's got to be more centromedian, I would think, rather than lateral, if you're getting myelopathic stuff going on. I don't really understand Brown-Sequard anyway, with a frank cervical disc herniation. But no, you've got neurological tests you can do. The first thing is you've got to make sure that there isn't a myelopathy. Everything else is very, very secondary to that. So you've got your long track tests. You can do sensation testing. You can look for spasticity by knee drop tests. You can look for clonus by dorsiflexing the ankle and stressing the quads by pushing the patella downwards. You've got Babinski. You've got you've got reflexes. You've got all the normal stuff you do for a spinal cord problem. As far as radiculopathy is concerned, Beaver's test will basically test the strength of the lower 6 abdominal levels. Again, I have no idea how good this test is. I don't know its specificity and I don't know its sensitivity, but it's one test you've got. You can also check the intercostal muscles. If you stick your fingers in between the ribs and get them to take a big breath in and hold it, the side with the weaker intercostals, you'll be able to slide your finger in the ribs much easier than on the other side. Apart from that, you're in trouble. Sensation is difficult because there's a lot of overlap through this area. So other than that, you're relying on neuropathic pain and or paresthesia, along with, well, if it's asymptomatic, that's what you got, basically.
What is can you clarify what Beaver's test is or go over that?
Beaver's test is you have the patient lay on their back, you visualize the abdomen. Let me see if I can draw this for you. Okay, so this is their abdomen, all right? There's their belly button. And you visually divide it into 4 quadrants. So basically, you've got the lower 3 quadrants of the thoracic spine dealing with the lower abdominal muscles there. So this is T10 through 12. Yeah. And then you've got I've lost it, 8, 9, 10, 7, 8, 9. 7, 8, 9 supplying these. So you have them sit up. Now, what should happen is there should be no movement. There should be an equal pull this way. Okay. So if we've got one of these levels weak, you're going to find that that level has lost its strength. So we say this one. So this is pulling more weakly there. So what you'll get is, sorry, you'll get that happening. So basically these two will cancel out each other. This one will dominate the pull and you'll see the umbilicus pulled down and to the left. And it's just showing you basically these muscles are weaker. Now, if you've got an upper versus lower abdominal imbalance, so the upper abdominals are stronger or weaker than lower, then you'll see it shift up that way. That doesn't help. So you're looking for an oblique movement of the umbilicus. Now, it happens very quickly, or it can happen extremely quickly. So you've got to be watching this carefully. And as the muscle contracts more strongly, you'll lose that shift. So you've got to look for it really early in the head lift. Okay, and it may just be a fleeting thing you see. Is that okay?
Yeah, thank you. That was a netter quality image.
Well, you haven't got one in your clinic, you know. If you had an MRI, fine, but even then you'd be wondering about it. I mean, if you've got somebody with any symptoms, actually, this isn't good. If you've got a patient with no pain, but you're finding neurological symptoms, that's worse than neurological symptoms with pain. It would indicate that this is probably not musculoskeletal and it is neurological. Now, in this case, you can have a disc herniation that's asymptomatic and giving you neurological things, but your assumption has to be that this isn't a locomotor system problem, it's neurological. If they find there's a disc herniation, then they find it on the back of that. But basically, with neurological disease processes, the neurological signs tend to be much, much worse than any pain they get. Is that okay? This isn't about making definitive diagnosis now. This is about safety. If you're looking at a radiculopathy and they're asymptomatic, that still needs to be imaged. You don't know why they've got that radiculopathy. If they're not getting back pain, you have no idea why. Their ranges of motion will be okay. Everything will be all right. So anytime you're not getting pain, but you have neurological symptoms, assume the worst and get it out, not the best. Is that okay?
Yeah, thank you.
Okay. Also, why is the frequency of thoracic disc herniations on the rise? Could it be mostly due to the increase in the amount of imaging that has been performed today? I have no idea. This could be anything. This could be a recognition that they are a bit more common than was first thought. It could be that the rate of the surgical practice is higher, and as they practice more and get better at it, they do more surgery. You get a bit more adventurous with this surgery after you've done it a few times. It's going to spread. I mean, basically, if one day there's not much thoracic surgery being done, a year later there'll be more done, obviously, because they're getting practice at it and they're being taught it by people who have done it. So it will increase. Doesn't mean to say the incidence of disc herniations are on the increase, just the surgical rate. Okay. So Ryan, we have talked about typical ages when cervical disc generally. No, I have no idea. I've never seen anything like that. I've got no idea about that, Ryan. Sorry, mate. With the rarity of symptomatic thoracic disc herniations, is there a significant difference in the size or composition of the thoracic? I had no idea again. But the reason given, the usual reason given why you see a lot less thoracic disc herniations than you see in other areas is the fact that because of the relative hypomobility of the thoracic spine, the mechanical stresses on the disc are much less, so they don't rupture as often. Seems to me a likely explanation. It's a reasonable one anyway.
But Jim, with that, you know, you in the video how the canal is typically quite significantly more narrow in the thoracic spine. So to me, it just seems like if there is a disc issue, that there's just more of a chance for that to
yeah. I mean, there's much more chance of compression of the spinal cord from a thoracic disc than there is any other region of the spine. Much more. It's just that thoracic disc herniations are so rare.
Yeah.
But when you do have one, the likelihood that it hitting the spine is much higher. Yeah.
Yeah.
Okay. So you've got to be careful with them. You really do. Now this was, where are we? This is Ryan as well. Oddly enough, about a month ago, I had evaluated a patient with right-sided TL junction pain and ridiculous symptoms from her spine to right thorax, somewhat following the T11 dermatome. Sent her for an MRI and she had a T11-12 disc herniation. They did an injection about 2 weeks ago. She's been doing much better since, as I said in the answer. You know more about it than I do, Ryan. Don't think I've ever seen one knowingly. Are you going to follow her up, Ryan?
Yeah, I'm treating her right now. She's doing a lot better. Still getting some, because what she was getting was just numbness and tingling that was crossing over top of her thorax and then towards her abdomen. So I sent her for imaging because anything wasn't making any sense to me. So
Yeah.
But she's doing well. The injections seem to help things down quite a bit.
That's going to be one of my comments. This is almost a diagnosis by exclusion. You exclude everything else and you see what you're left with. When you see her, try Beaver's test with her.
Okay.
I don't get the opportunity to do this, so do it and then let me know, would you?
Yeah, I can definitely do that.
Excellent. Caleb, recently I've had a couple of patients come in with thoracic spine pain which seems to be more related to the lats than the actual spine. Is there a biomechanical dysfunction that occurs in the thoracic spine that can lead to increased tone or spasm in the lat? Both these patients seem to do well with general PAs and stretch and have since been discharged, so I'm just wondering if there was something else I could have done as well. All right. First of all, understand and remember that the innovation to lat is cervical, not thoracic. So if you're getting hypertonicity, they have a problem in the neck. It can't be coming from a thorax. Now, it's not to say the thorax can't be buggering up the neck, and that's causing the hypertonicity, but it can't really, as far as I know anyway, it can't be coming directly from the thoracic spine. The way to deal with this is the way you would deal with any biomechanical dysfunction. Find out what the problem is and treat it. Now, the examination of the thorax, the biomechanical examination of the thorax is pretty much exactly the same as the lumbar spine. You can do position testing followed by P-PIVMs and PAVMs. Otherwise, it's down to you doing P-PIVMs in sitting, which get awkward, and if they're a big patient it gets really quite difficult. But you do much the same thing: flexion, extension, side bend and rotation, or you combine the movements, feel for the movement with the spinous processes, and then do your glides, but treat it the same way. Okay, probably right now what you should be doing is assess. I know you haven't done this yet, you haven't done the class for it yet, but there's no reason why you can't extrapolate the knowledge you've got from the cervical and lumbar spine and use it on the thorax and see how it works for you. Is that okay?
Yeah, that works. Thank you.
Okay. Michelle, annulus tears, rim lesions, in-plate injuries, etc. Can they be differentially diagnosed? This is his neck now. Differentially diagnosed in the clinic or only with diagnostic ammo? They present differently from each other, and what other implications for rehab? All right, you've got an acute. These are all acute lesions. I mentioned this before, particularly in the neck. You can't tell with an acute post-traumatic neck pain what's going on. They could have a fracture, they could have a rim lesion, they could have torn a ligament, they could have muscle tears. This is an acute problem. You really can't tell now from physical examination which it is. So you get rid of the diagnoses that you can get rid of. You can get rid of a fracture, actually a fracture, annular tears, rim lesions, end plate injuries. All of this structural damage will show up as severe immediate pain after the trauma. So when you're getting that, your job is not to, you can't really differentiate those. And you know this, you know that you can't move a patient. These patients can barely move. And this is a lot of your MVA patients, but they usually don't have that immediate severe pain. So that would differentiate the acutely painful neck that isn't structurally damaged from the structurally damaged neck. And it's that immediate onset of pain. You've also got the C-spine rules. And if you want to use it, the Nexus LRC. So you've got those two X-ray rules that will help you determine if there's a fracture or any other healthy tissue discontinuity. Okay. Now, if you want to differentiate them from disc herniations, they don't look like a disc herniation, at least not one that's given you a radiculopathy and everything else. So this is really what it comes down to. I don't think that you can differentiate out, other than through the subjective exam, acute structural damage. Is that okay? You assume when you've got that history that they have fractured something. Now, if this is central pain we're talking about now, if you're talking about lateral pain, then it may not be that dangerous. So it may be a torn muscle. For example, you've got anterolateral pain. What you may have there is a torn sternomastoid. On the other end, it may be a torn carotid artery. So the way to tell the difference there is to actually palpate the sternomastoid. If the sternomastoid, and you don't palpate by going anterior until you pinch it, so you don't disturb the artery. If the muscle isn't torn, then you assume the artery is. But central pain, you have to assume the worst. You good with that?
I actually did not ask that question. I'm not sure if there's another Michelle in the group.
Okay. I didn't think he was coming today, Michelle. Oh, it's Deb. That was Deb. Sorry. Okay. Deb's not coming today. I've lost it. I've lost it. I've lost it. I don't know why you're on there anyway, but I'm going to blame you anyway.
Fair enough.
Okay, this is from Deb then. Horner syndrome, how to recognize it and other serious complications of trauma in the chronic post-MVA. What do you do if suspected? Once since we get the pain to the MD's had time to consider it, or he thinks it's been thoroughly examined. Well, they're wrong. Horner syndrome, though, can be tricky. Horner syndrome may not be present unless the patient's tired. It's also not that easy to see. I think we mentioned this in the neck, but the meiosis, for example, may not be obvious unless the patient's in a darkened room, so that the normal pupil actually dilates, and that's when you can see the difference. Otherwise, there's not that much in a normal lighted room, so they may have to be in a slightly darker room. The first thing you'll probably notice, if you notice anything at all, is that they just look off, and what that is that one eye looks further away from you than the other. And this is exophthalmos. And as I said, basically, it's believed this is an optical illusion caused by the narrowed palpebral fissure. The upper eyelid comes up, the lower eyelid comes down. So this isn't just a ptosis. It's not the lower eyelid drooping. It's both of them going towards the center. So the gap between the eyelids is much smaller. The pupil's a bit smaller as well. So it makes the whole eye look as if it's pulled back into the skull. That's probably the first thing you'll notice. If you do notice that, then look for the rest. So to see sweating, you're probably going to have to run your hands down their face because it's unlikely you'll be able to see it. So you just run down this way, and the side that's drier, you'll slide faster. The color discoloration, the reddening, may not always be there. It's more there, more consistently in children with this. It does happen in adults, so, but you're looking for one side of the face to be a bit redder than the other. But the main thing is around the eyes. So it's not always easy to see. I think I told you the story about the patient who somebody brought it into a class I was teaching, and the patient realized there was something wrong when he went in after gardening, and his wife said, "What's the matter with you?" And he said, "What are you talking about?" She said, "Go and have a look in the mirror." And he looked in the mirror, and one side of his face was covered in dirt and the other side wasn't. So the dirt he was and the dust he was kicking up was sticking to the sweat, wasn't doing it on the other side. That's how he noticed it. So it's not always that easy to pick this stuff up. As far as talking to the doctors concerned, you can either be subtle or not. What I took to doing was simply turn around and say, "Listen, since you saw them, I think they've developed X. All right. And then just reel off the symptoms. There's not a lot of percentage in telling them that they've missed it. All right. You know, they've got very fragile egos. And if you want to get stuff done, bruising them isn't the way of going about it. But your first consideration is the patient, not the doctor's ego. Is there anything else on that you want to talk about? Okay, myelopathy versus central canal stenosis. This isn't that big a deal. Is there a fine line between those which are keep in the clinic and those which send back to the MD, or are they one and the same? Is a deciding factor positive long track test? All right, central stenosis actually isn't a diagnosis. It's a statement about the structure of the spinal canal. You can have central stenosis and have no symptoms whatsoever. It's what the stenosis does. So in the lumbar spine, central stenosis can produce cord recliner problems. You don't want that. That goes back to the doctor. In the thoracic spine and the cervical spine, it's going to cause spinal cord problems. Those you want to send back to the doctor. So it's a matter of not whether they got central stenosis. It's a matter about what the neuropathic problem they're causing is. Is that okay? I've screwed up the coloration here. The next part should be in blue. It might be too soon to ask this, especially having a chance to much material, but is there a particular presentation that helps you differentiate thoracic disc from other thoracic discs? No, I've just answered that. I think you're going to be lucky to differentiate thoracic discogenic pain from other pain, let alone thoracic disc herniations, to start with. As I say, I think this is going to be a diagnosis of exclusion. If it's not a segmental dysfunction, it's something else. If you're picking up a radiculopathy or a myelopathy, you don't care. All right, these need to be imaged. If on the other hand, you're not picking up any neurological signs or symptoms, then you're going to have to go through your exam. And if it's not making sense, you assume, well, you can't really assume it's a disc herniation. You've got to assume something, but a disc herniation is something you can assume and get it seen to, because you've got nothing to treat. If you can't diagnose it, you cannot treat it. I mean, you can treat the pain, but if you don't know what's happening, you probably shouldn't. You should find out what's causing the pain. Is that all right? Don't get, like, what you don't want to do is keep hold of people you should be keeping hold of. This isn't something you're going to be doing every week. All right. It's not like every other patient goes back to the doctor because you can't figure it out. Don't forget, you've got colleagues, you've got other people you can send this stuff to if you're not sure. But the end point is, if you don't know what you're treating, and there's any sort of a chance of it being more serious, then get rid of it. If you don't think it's serious, then you can try treating the pain, needling and so on. But you want to be careful about what you're doing.
Jim, what do you think is the one biomechanical dysfunction that would look most like a disc when they came into the clinic?
I think it's probably going to be the anterior the anterior translation subluxation, because that can be really, really acute.
Is usually a recurring thing, or is usually like a first episode that's usually acute?
Well, it's unusual for you to see a first episode of anything.
Yeah.
You know, but the trouble is you don't know if it's a first episode or if it is an episodic.
Yeah.
Yeah. I don't know if did I tell you about my friend? I had dinner with him a couple of weeks ago, and I stayed over on Sunday.
Yeah.
Yeah.
You didn't tell us the follow-up. I think you were to follow up with him.
She still went. Yeah, she's still waiting to see a neurologist. But you know, the guy who treated her first did needling and got rid of most of her back pain. And that's when the paresthesia in the leg started, or the numbness in the leg started. And I was talking to this on the class, and somebody said, "Well, did he cause that?" Well, of course he didn't cause it. I mean, how deep have you got to go with a needle to cause neuropathic changes? No, but what he did was, it was unforgivable, actually, as far as I'm concerned. He ignored the fact that she had lost massive amounts of sensation in her legs and still treated it as if it was normal. That's what's wrong, not the treatment he gave, but he gave any treatment at all. He didn't even bother assessing her legs afterwards. Now, I don't think he caused it. What he could have done was relieve enough muscle tension so whatever was preventing this from happening happened, but he wouldn't have caused it.
Guys didn't know if they ever came to a conclusion on what it was.
No, she's waiting to see the neurologist. This is the thing. I mean, this could be something like MS for all I know. MS often starts off with severe back pain, you know. That's not going to kill her, but somebody needs to find out about it. And I think that bloody that therapist should have something done to him. Needs more education. Actually, that's one of the problems with needling. You get so enthused about needling, it works on everything. Yeah, so you give it to everything. Does there happen to be any known link between thoracic disc pathology and scoliosis? Just wondering if the abnormal curvature would predispose someone to a disc injury in this region. Again, I haven't seen anything at all about this, but if this is a rigid scoliosis, then there's going to be even less movement than usual, and I would think there'll be less trouble with the disc. Your problem tends to lie where the mobility changes, where you go from rigid to mobile, and they're the ones that seem to take the hit. But I haven't seen anything on this at all, Krista. Okay, that's it. Any questions for me? Okay. Yeah. Sorry, say again.
Jim, in the Adrian Lau paper, they were talking about the Cloward's areas. Could you go into a little bit more elaboration of how that chemical activation of the DRGs and cervical spine creates that referral pain?
No. I really don't bother myself with that sort of theory. I really don't like pain theory.
Okay.
Yeah, no. Dave, can you?
Yeah, Cloward's area has been around for what, 50 years? It's funny that a lot of people haven't heard of it in that sense, is that you'll see that the different spinal segments in the cervical spine will refer down along the scapula in the kind of what you saw in the article in those general areas. As to the reason for referral into those areas, it's somewhat mixed because neurologically, it doesn't make clear sense. So on that, I've never really gotten a clear answer on, okay, this is the pathway by which C6 is going to refer down to the mid-scapular border, and C7 is going to be just inferior down to the inferior scapular border. So unfortunately, I don't have a good answer for you right there. It's just one of those known entities that you'll see, is that you'll see patients with this, and it's not everybody, but time to time, this tends to pop up. And then it's also too, you need to also look at the thoracic spine in this individual to make sure, okay, this isn't a pain of thoracic origin versus cervical origin. So, but anytime you're looking in this region, you're probably going to screen the thoracic spine anyway, or cervical spine. If they're coming in reporting a mid-scapular pain, you definitely want to look at a thoracic biomechanical exam. It kind of triggers anywhere up in that region. And that's where you're going to find that, okay, I can't locally stimulate or reproduce this pain. But if I go to the thoracic cervical spine, you may find something up there that reproduces that referred spot. But it's always on my rule out or differential list. If I see somebody with mid-scapular pain, is that I need to look at cervical spine, or I ask them if they have cervical pain. I'll look down to see if they have referred pain in one of those regions.
Theriacs always put it down to the dura. Simply because the dura can refer all over the bloody place.
Yeah, that would, and yeah, I mean, I can't think of something better to do it.
No, I can't either.
There's in there also is notalgia paresthetica, which I've had 2 people referred to me for that, both of which were biomechanical dysfunctions that were diagnosed as basically, radicular pain in the thoracic region. And, it kind of comes in the same way, a burning pain that's in that region. But both of them, when I manipulated either transverse subluxation or I manipulated the rib, basically 80% of that pain went away. And biomechanically, you straighten them out, it goes away too. So that's why in that article, it's nice to have these different differentials, because then what you're doing is you're playing these things off of each other. But, you know, for the fellowship, we need the pain theory stuff in there, but it's also understanding the context and where it exists. And you even see recently, I mean, Chad Cook came out and said, you know, when you look at the pain science, these true central or sensitization patients are probably maybe about 10% of what you may see, maybe less. So as much as pain science has garnered a lot of this enthusiasm and attention, it's going to be a very small subset of what you see unless you're in basically a chronic pain clinic.
Yeah. Yep. That's why I've got no real interest in it. It's boring and isn't particularly relevant to your clinical practice. Yeah. Okay, I'm done. Dave, do you want to do anything?
Yeah, I got some time. Maybe let's do a case.
Actually, can I ask a clinical question to you guys quick?
Mm-hmm.
I just evaluated a guy yesterday for pectoralis pain, and he had originally injured this back in this, he said spring. He had COVID, and when he returned to the gym, he just had kind of diffuse pain. He was seen by a colleague of mine for like just a pec muscle strain and had mild relief of symptoms, but now he complains of this nagging pain in the armpit region. And so I had trouble really palpating. I guess I got on pec minor and he said it was a little bit uncomfortable, but most of us are uncomfortable there. He did have kind of lock. He was a little bit hypomobile C7. So I did some mobilization there and no major changes after that. But I was just curious, when we've talked about like lumbar spine and psoas, and we kind of talked about how that can be, doing like a psoas release can kind of be a waste of time. So I was wondering about pec minor, if it's kind of a wasted area to try to work soft tissue, if it's usually hypertonic because of a segmental issue, CT junction or something like that.
Okay, hypertonicity is facilitation or it's neurological. Can you give me a minute, guys? Dave, can you take it on for a sec? Sorry, it's my real estate.
That's what you think of. You get this case given to you, and it's just kind of like, yeah, you know that, you know, one, I would treat the local area because the patient's expectation is that, and you can do desensitization. But I'd be doing what you're doing is looking at these other regions, and you're going to look at probably first and second rib up in that region, you know, maybe going down to 3 and 4 as possibly being involved in this one, because that would be hypertonicity. You can look at balance of the scapula. So understand, like we did in a little bit in module 2, was looking at the scapular position. Do I see winging? You know, what is the scapular position? Because if you have hypertonicity in pec minor, you're expecting it to be kind of drawn upward and toward there with probably medial border or inferior border winging.
He does have medial border winging.
Okay, so it's the medial border that's winging. So then part of it is that, okay, do I need to get this kind of rebalanced? So at that point now you're looking at AC joint and also SC joint and position, because a restriction there could be driving the scapular medial border. So if you're looking for, okay, what are etiologies of this potential musculoskeletal pain? It's probably a segmental dysfunction somewhere or a mechanical dysfunction. Etiologies that I would screen with SC joint, AC joint. You know, we looked a little bit at rotations on the course. So I may just kind of rest my hands on his shoulders and you get a sense of, do you sense that he's more rotated to the left or the right in the upper thoracic spine? And palpate the first and second rib, or second and third rib. Probably you can go down to 4 or 5 even anteriorly, and just to see, is one feel more prominent on that side? Is one of those ribs being compressed in that would need to be released? So if you find that at 2 or 3, that may be the rib you end up going in there and manipulating, or the ring that's stuck that needs treatment. I would look for those things.
And you're looking more like at the thoracic rib junction. I mean, I know you palpate it anteriorly, but that's what you would be working on, correct?
Yeah, I work back there. You can do a release. You can basically just do like a ring stack or a breathing technique where you can just kind of use basically the pisiform or the medial or the lateral border, your medial border of your hand. And you can glide the rib anteriorly and try it. It's probably sometimes less effective for me, but since it's an anterior pain that he's having, I'll start there, because then the patient gets the sense that I'm working on his pain, and you can describe the ribs involvement in his pain pattern. And that, first we're gonna look at the rib anteriorly, and then I'm gonna look at the rib in the back, because, it's gonna attach back there, and that can impact the pain in the front, especially with the scapula bordering medially or winging medially. Bring all those things to the patient's attention so that he understands why you're going to the back with him and trace the rib. So, make sure you sell it a little bit, so you don't, so the patient doesn't feel like you're getting too far off of what his primary complaint is. But that's what I'd be looking for, is what was going to create this hypertonicity in a pec minor. And I don't think of the pec minor as being like a primary.
Okay, awesome. Thank you.
Does that make sense?
Yeah, absolutely. And that's what I was thinking anyway. And he kind of bought into, hey, I'm going to look at your cervical and thoracic spine,
yeah.
and this might be the problem. Younger guy, so he's pretty on board with it. He just wants to feel better. So.
And you can also kind of do the scapular lift, like the unweighting technique is easy, where, if it's, let's say if it's his left shoulder, I'm going to pick the scapula up with my right hand and just grab the anterior shoulder with my left hand and kind of bring it back and center it and just unload it. And if unloading it gives him relief, then he gets a sense that, okay, I need to get this muscle balance better, whether that his scapula is winging and protracted, and that's what's kind of creating the hypertonicity. If he gets it balanced and you support his scapula and unload it, it's less painful. Then he starts to understand that I need to find the position to unload my scapula. Whether it's using an armrest at work, and doing all those other things that would take the stress off it. You may find if he has a desk job and his arm is always in a cocked or ready position, then adding armrest use makes a big difference in an individual like this.
Okay, awesome.
They're always forward toned and lean.
We're still talking about pec minor.
We are.
Okay, first, what side is this on, left or right?
It's left.
Make sure it's not heart.
Okay.
Like if he's torn the muscle, that should have been intensely painful, and it should be intensely tender. Also, when you're looking at pec minor, did you compare it to the other side as far as tenderness is concerned?
Not.
You've got to. You have to do that. You can't palpate one side and say it seems a bit tender. It's got to be palpated against the other side.
Sounds good.
You have to do both sides equally. Okay.
Yep.
Okay.
I have a good feeling somewhere in the whole package we just talked about, you're gonna find it. Again, finding it is always a bit easier than treating it, but you're gonna see the relationship there. As we looked a little bit about just clavicle motions, those are fun things to play with, because sometimes you really kind of stumble upon it and realize, okay, yeah, I get the clavicle moving better shoulder rotation. These things can unwind faster. But then there's always the treatment portion that's required of, okay, you need to get it rebalanced. He needs to fix these small things in his everyday life, how he works, his work position, what's he sleeping in, his television position, how he holds his phone. So think in terms of his life in 360 and make sure you're not missing the variable there, which can be the driver. That's often where if I find I'm not making improvement with a patient, it's often the thing that I've overlooked. Like there's that driver that they're always doing. And once I get that cleaned up, then it tends to go better.
Awesome. Thanks for the input.
Okay. All right, guys. Dave, you want to do it?
Yeah, I'll take a few minutes.
All right, I'm gonna
Might as well
go out. I'm gonna leave this running so the recording's on. I've got to go out though.
Good.
Oh God, everything happens on the last bloody day. Everything.
Surprised you're still in Canada.
Tomorrow morning I'm out. I'm COVID free and I'm able to fly. So I'm gone tomorrow morning. All right, guys. Told you.
Thanks, Jim.
Thanks, Jim.
You're welcome.
All right, well, I guess before we do a case, I should ask, I restructured the website a little bit with the information. Is anyone unclear on the links at the top taking you into each separate category versus having them listed at the bottom?
I think that's nice to have there, Dave.
Okay. What I'm trying to do is I'm trying to build the prep module for the thoracic in what's called the book. And I'll create different subsections, which kind of follows along the skills list. And I'm going to put in comments and I'll take notes out from the videos. And you can use that as the course prep. Again, I put the old Gale slides into the fellowship materials. The fellows need to review that. And that is completely optional. But when reviewing for this, I'll send you the fellowship articles, which I think are helpful. but they're not mandatory. And I think if you review along those, it should follow along the lab. Again, Eric may teach it slightly different, just coming from kind of a different family tree, but I think that'll just kind of guide you better what the lab will look like and prepare you. So I think if those aren't fellows, I think that'll be a clean way to do it. And if there's a better way for me to do it, or you have something you like, please email me and let me know. But I think that'll simplify the process for you. And about each week, like I just put up neurological, I'm going to put up biomechanical probably this weekend, and I'll start putting up the manipulation techniques. But again, you don't have to memorize these techniques because you will get them on the course. This will be way more valuable with post-course prep. But hopefully what it'll do is it'll kind of make what I did in the cervical modules. It'll give you a lab manual to follow. So you have a little bit something that's better that'll correspond to what you're learning in the course. So that's kind of what I'm shooting for on this one. And I am wide open to feedback if anybody has it.
Dave, I just have a question. For the expectations heading into the Thursday Zoom meetings. Are those going to be in the book? Is that what the weekly course prep is? Is that what?
Oh, no. In the book, think of it being two different things. This is basically the didactic, and I will continue to put it into like the videos, the video prep and the video, Zoom sessions into the Word document or the document that I post. What I'm putting online for you to review is basically the course prep material. So if you want to prep and look at the videos and review the material ahead of time, you can go to the book, and basically what I'll do is I'll put down notes for all the techniques, and I'll also put in like clinical notes, like what would I teach, or Eric teach, or I'm gonna get Scott to contribute to it. So you kind of get some thought process behind what are we looking at with these cases. I sent out the thoracic pain article because I thought, what I want fellows to do is they basically comment on it. But I thought it was a nice summary to kind of round out some of this discussion with disc pain, because there's disc pain, but there's all these other pain generators that also exist. And kind of like with the illness scripts, you can look at it and I can basically work between these different differentials. And what's interesting about the pain in the thoracic spine is some of the biomechanical dysfunctions, are not addressed adequately in that article, but it's really about that central pain. Did I answer your question, or did I go tangential?
I think you answered it. Yeah. So I'm going to keep looking at the Word document for the weekly, the expectations leading up to.
Keep looking at the Word document. I'll send it out for the video preps. Okay.
Okay.
If there's an article I think is handy, I'll send it. It's not mandatory. Cool. But that's more for the fellows to round out kind of the concepts. If you want to prep for the lab, then the book that I'm creating will be all the lab techniques, as well as just some light discussion on those techniques. And I'm pulling in material from what you would see in Gail's PowerPoint. So it'll be kind of blended in there. I think you should be able to print out that book. If you at the end want to print out like a lab manual, it should be that you should be able to print that whole book thing out by chapter, and it'll basically give you what'll amount to basically a lab manual. Awesome. Now, what it won't have is pictures of the techniques. I do have one of those, but at least it'll give you some guide.
Okay, thanks for doing that.
Hey, Dave, I have a question.
Yeah, shoot.
I just have a patient that has a lot of thoracic pain on the right side. What's the likelihood of like a fracture of the ribs or a compression fracture in general without trauma? He's like in his late 50s to early 60s.
Is it pain lateral, like on the lateral border of his rib cage, or is it more in the back, like around the transverse process?
It extends, so it starts like on the transverse process and then it kind of wraps around.
Now that's probably less likely a fracture without trauma.
Okay.
It's such a meaty area there. Where most of your rib fractures are going to be is it's kind of like a compression thing where, the rib is kind of like an accordion. So when it bends like this, it fractures like, laterally.
Right.
In the back, what I would expect it to be is had to be some type of blunt trauma, fall on an object, got hit by something.
Okay.
Something that's got to input an impulse force through the muscles enough to fracture it. If he's getting radiating pain there, and it's wrapping around the rib one, you watch to make sure it doesn't increase, and it's not like a radiating pain like that. One of the differentials you would always think about is, okay, is this shingles? you know, but it doesn't sound like
Okay.
it's probably not increasing.
No,
So what you
no,
then
it's
there's
just staying constant.
is that, how about the rib glide? Did you try and translate or mobilize the rib?
He just doesn't move efficiently at all through the thoracic. Like he has
Yeah.
he lacks lordosis in his lumbar spine.
Uh,
And so, and he's like, when he's in prone, he really, he has a lot of crease lines in the lumbar spine. So he just doesn't move efficiently of the thoracic spine at all.
mhm.
So it's just really stiff, and he doesn't have, like, he lacks, right arm, with arm motion, with ambulation. He just doesn't, almost seems like he just doesn't rotate very well through that region in general.
So he probably moves lateral when he walks.
Probably, yeah.
Probably goes side to side a little bit more. Or moves right
Yeah.
at fixed axis. I like to think of these individuals as having 25% more range of motion than they show you. So that if you kind of can go in either through neuromotor input, through the thoracic spine, rib cage, facet joints, or general movement patterns, and you increase it, they will move and do better. So
Okay.
he's a good one where I don't think I really did a lot of mid rib palpation in the courses. But if you go in there and just think about working rotation, what I want you to do is just like I put the rib palpation videos up in the book. I would take a look at
Okay.
those and palpate them. And what you can see is it's
Okay.
technically diagonally, which is pretty good. And you're going to take your hand and you're going to kind of wrap your hand around the rib. So my index pad would probably be on the lateral part of the rib. I'll get a caliper grip on it. I use that for
Yep.
mobilization. I basically will
Okay.
get on the ribs of that individual and work in rotation. And you know that these ribs, I haven't put the videos yet for the biomechanical, but I can post Diane Lee's article on the direction of the glides. And
Okay.
if you take the ribs just loosely through their glides and mobilize them, you'll get a sense of where some ribs move better than others. And you can come up with what is stiff. But think about just proprioceptively, if you add up the motion of each joint and mobilize these joints in the summation of 7 or 8 joints, he's going to gain a lot of range of motion. And that may free him up. This is likely somebody where once you get into the thoracic module, you're probably manipulating either the costotransverse joint would be the most likely one because you have the nerve resting so close to it, so that if he's restricted at his costotransverse joint, it will drive a pain pattern that looks like this. So if you're comfortable mobilizing that joint, it's a good way to do it. It's just always a little scary when their pain level is high.
Right.
But the good way to practice your palpation technique and work on mobilization and movements of the rib cage, just getting a sense of how they feel, is using that approach where you can start on the lateral rib, follow the rib back up to the transverse process, and then you can glide side to side on both sides. You feel, okay, can I translate right and left? You're going to come to that segment where the one side pushes and the other one doesn't. And that's the one you know that, okay, I'm going to spend a little bit more time working on, even if it's just rotation through the spine at this segment. And because some of these things are restricted, but they don't always need to be manipulated. Sometimes the rotary mobilization will work quite nicely. And it also reintroduces motion at these segments because they just are so used to not moving them. So I find that really helpful from a palpatory standpoint and also kind of a treatment standpoint.
Yeah, that sounds good. Thanks, Dave.
Yeah, no problem. And again, if you're the traction technique would probably be the one to go to one. I think I may post that out to you if you're comfortable with it.
Yeah, that'd be awesome.
Okay. Cool. Got another minute. Any other questions? Feel free to send me again. I want you to get the most out of these Zoom sessions. So about doing cases and some other things. This we kind of modified it a little bit. If it's going well. Just any other recommendations on how to increase your value in this time? Please feel free to email me. Let me know. And for those of you who are fellows, some of you already received the link to Slack for posting to a question. So it's we're going to try this. So what I want you to do is I posted the chronic pain thoracic spine article there. Basically, all the fellows will be on that forum. And what I want you to do is basically when you read the articles, we'll start posting there. The video blogs, whenever terribly bad. So I think if we can get everyone posting in there, we'll do the articles through that. And some of the fellows have already received it and joined. The ones who haven't, I'm going to get you guys on, and we're going to do the article, try and do the article discussions there. If you are interested in these articles or curious on ones who lurk, then email me and I will add you. All right. Other than
Dave, so I
that,
got a question.
Mhm.
Are we, do you want us, the fellows, to go back and post in Flipgrid then, or are we just moving forward with Slack?
I think we'd move forward with Slack. I think the video is just not something that everyone is into. And I think if you do Slack, then you can download it onto your phone. You can download the app, and it becomes very easy to do.
Okay.
So I think we're going to try to see if that'll be an easier format for people. Because I mean, how are you guys doing with Flipgrid?
Not well.
Yeah, that's fair. You know, you try things and some things work out, some things don't. But that's where Slack may be a nice one, because you can just download the app, read the article, and then just post something out on it. You know, right?
Yeah, I was looking at the app the other day, and it looks like super easy to just like reply in like a thread, and then being able to like comment on other people's posts would be helpful too.
Yeah, correct. So that's what we're gonna try doing going forward. I think this may work. This may work a little bit better, more efficiently. Because that way you can do it on the fly. It's less effort. And I'll try and put out just, you can post anything on it, but I'll put out just general topics, how it relates back. Like I like the thoracic, chronic pain, thoracic spine, because you can almost think of it from an illness script standpoint. Like everything, how they talked about it. How do I differentiate between, you know, basically, you know, neural sensitivity, dural pain, you know, referral, Cloward's areas, and everything else. So cool. All right. Cool. Again, well, I'm done. So if anyone else has anything, feel free. You good, Tanner?
Yeah, I'm good.
Okay. Cool. Yep.
Thanks, Dave. Thank you.
All right. No, hey, take care.